Good afternoon, everyone. This is Jeff Burton from United Physicians. We have a couple other people here at UP in the room with us. I'll let them introduce themselves. But today we're going to be reviewing the trend reports. Hopefully all of you on the line either have the trend reports that were sent to you by Wendy or able to access the webinar. There's a phone version and obviously a computer version where you can see some samples of the reports we're going to be pulling up here. So I'm a part of the medical management team at UP, and I'll let everyone else here introduce themselves.
I'm Jenny Stout, Professional Development Consultant for the Beaumont Employed Physicians.
And this is Dr. Kim Coleman, Medical Director at United Physicians.
Okay, so we're going to be going through four different types of reports. The primary care physicians received 2 reports, and the specialists received 2 reports. So at different points throughout the webinar, I'll pause for questions. If you can mute your phones right now while I'm going through the first set of reports, that would be helpful. And then when we open it up for questions, obviously don't forget to unmute your phones. The trend reports are really a first step at identifying where you stand as a physician as far as quality, utilization, and cost metrics that are measured by the health plans. It's becoming increasingly important as payers are making information transparent to their members, designing benefits and networks around high-performing physicians or physician groups. There's incentives for physicians who can reach a level of performance that's favorable compared to their peers, or in some cases a regional benchmark. These trend reports hopefully can provide a first indication of what areas you may need to work with UP and Beaumont to investigate what's driving particular trends or a metric score that you see on your report. We've included some fairly basic measures in the trend reports that are common to many of the health plans, just in order to give you an overview of your performance over time, and then your current performance as far as comparison to the rest of your practice as a whole, or how it compares to a benchmark. So like I had mentioned before, there are 4 trend reports that we produce here at UP. Right now we have the first trend report for the primary care physicians displayed on the screen. It's titled the BCDSM PCP Physician Trend Report. And like I had mentioned, the primary care physicians have 2 reports, a Blue Cross trend report and a managed care trend report. And the same thing goes for the specialists. So we'll start with the PCP reports, but it's good for everyone on the line to pay attention. The reports are structured similar, the layout's similar, it's just the metrics are different. So if you're looking at your reports or following on the screen, there are numerical values on the right side of the page that may be in different colors. All the benchmark values are blue. The practice unit values, meaning your practice unit as a whole, are black. And the physician scores can be one of 3 colors. If your score is red for any particular metric, that means it's unfavorable compared to benchmark. Green means it's favorable compared to benchmark. Or black means that there's no relevant comparison to a benchmark. If you happen to have a value that's displayed as NA, that means that either you don't have that age in your practice, so an internal medicine physician wouldn't have a PEDS metric, or the physician doesn't participate with that health plan. And finally, it could be the case where we just don't have enough data to populate that measure. The graphs on the left side of the report represent data points going back to 2011 of October and ending with the most recent data we have, which is through March of 2013. The middle of the page provides a description of the measure and its source. So the data that we receive from the health plans is about 3 to 4 months delayed after the actual service was incurred. That's necessary to capture all of the actual paid claims. We also need time to organize the data and then produce these reports for you. So it may not seem that it's real time or very current, but it's as current as it can be. And the purpose really is to identify patterns or trends over time so we can help you implement changes in your practice, whether it be a lean process improvement, adherence to new evidence-based guidelines, changes in your referral pattern, or improved communication between a PCP and a specialist. We do have the ability to supplement this type of report with more detailed information about your attributed patients as a PCP. This type of request would be on an as-needed basis, and UP and Beaumont administration would work together and be available to support you in those requests. So back to the actual report here, the benchmark score for the first three measures that you see, generic use rate, high-tech radiology, and ER utilization, are based on Milliman moderately managed benchmark for Southeast Michigan. Milliman's a worldwide leader in healthcare analytics and used by payers for benchmarking and measurements.
We're doing that right now.
These benchmarks you see here are fairly aggressive, and we chose them as a highest common denominator for the reason that if you were to achieve this metric, or you achieve the benchmark at a certain metric that was a Milliman metric, it would be met across all of the health plans. The radiology, generic use rate, and ER metrics are three very important metrics that relate to the Blue Cross Blue Shield of Michigan PGIP program. And they happen to be, at least generic use and radiology, areas where UP as a physician group tends to underperform when we're compared to other physician groups across the state. So one thing to keep in mind when you look at these measures here is that they are population-based measures. That means that they account for services provided to your patient population in any service setting. So not just within the walls of your practice, but maybe a specialist wrote a script, or your patient had a CT scan done at Beaumont. All inpatient data is excluded. So these reports only reflect outpatient or office. This way, it's very difficult. I know some people say well, how can I manage that if it's specialists writing scripts or services being done at a facility? The way the health plan does this is how we receive the data. And the purpose for doing this is to encourage more collaboration between physicians in the hospital. So with the help of UP and Beaumont, we can help you understand this data so you can manage your patient population more effectively. There'll often be times as a PCP when you identify your score to be unfavorable to benchmark. So let's say you're looking at your high-tech radiology score, and it happens to be, in this case, it happens to be red, 165 compared to the benchmark of 140, meaning that this particular physician's score is, there's more utilization of high-tech radiology services compared to the benchmark, which is the Milliman moderately managed care. If you find these instances and you're not quite sure why, and you have a suspicion that you may have a specialty group that orders a lot of images, or they're being done in the ER, etc., there are additional reports that we can provide to help you get to this level, but the trend reports are at least a start to help you focus your attention. So as we move down the page, the next measure is the quality score, and this represents the evidence-based care quality measures, such as HbA1c testing for diabetics, beta blocker therapy for patients with an MI. These are all derived from NCQA's Healthcare Effectiveness Data and Information Set, otherwise known as HEDIS. The benchmark for this particular measure is a little bit different. It actually represents the PGIP average for all primary care physicians across the state that are in the program. The final measure of the report, the PCMH capabilities. These are the total capabilities for patient-centered medical home that were reported to Blue Cross in the last submission, and that counted towards the 2013 PCMH evaluation. The benchmark we chose here is an arbitrary number of capabilities, 100. We felt that this was a decent gauge to keep pace with the implementation of PCMH capabilities we see in other physician organizations across the state. I'm going to jump over to the next trend report for PCPs, which is the managed care PCP trend reports. After I go through this, we'll open it up to questions, and then I'll move on to the specialist trend reports. Excuse me. So the managed care report looks very similar to the Blue Cross Blue Shield of Michigan trend report. The first three measures here are identical. However, the only difference is that this report is based on BCN and HAP patients. The benchmark for the first three measures is the same Milliman benchmark, but it's labeled differently. It's labeled network target instead of benchmark, only because these health plans have actual targets that our physician organization, UP, must achieve as a whole. The fourth measure down is something I want to really focus your attention on, and that's the performance index. The performance index is unique to the managed care report. Specialists can actually find this measure on their managed care trend reports as well. It's calculated with UP's profiling software based on claims we receive from the managed care plans. It's a measure of efficiency comparing a case mix adjusted cost. Case mix adjusts for differences in a patient population of the physician to a peer group average. And in this case, the peer group is all other UP physicians within your specialty. A higher performance index, in this case here you see on the report we're displaying on the screen, indicates that your costs are higher compared to your peers when treating your patients, and vice versa for a lower performance index. This is a really important measure because cost is becoming increasingly important, and collectively as a network, if we can manage our costs better relative to other physician groups, of course accounting for that difference in patient mix, the better off we'll be in a relatively new era of healthcare reimbursement, which is basically rewarding for value, not volume. This particular metric provides an idea of how your practice compares to others in your specialty. If it's higher, we can help you identify a diagnostic category or service level category that may be driving that. There are some things that may be actionable, some things may not, but the work we've done with several offices so far in some of our specialty steering committees show that we do have a lot of opportunities to reduce our costs, become more efficient as a network. You can scroll down, thank you. So the final measure here of the managed care PCP trend report is the quality score. This represents the quality score similar to all the HEDIS metrics that I described earlier from the BCN and the HAP websites. These come directly from the health plan. So before going to the specialist trend reports, do we have any questions on these two reports? And don't forget to unmute your phones. I think we had muted some people too, so give us a second here to unmute everyone.
Well, while people are dealing with the logistics, one thing that I wanted to point out, this is Kim, on the Blue Cross Blue Shield of Michigan reports, Jeff had mentioned the areas of generic X-ray and high-tech radiology as being important areas for us to focus on as a network because our performance traditionally has not been as one of the leaders in those areas. I just also wanted to mention that the quality score, those EBCR scores, that's another really important one to keep on your radar screen because for those primary care practices that are either pursuing patient-centered medical home designation or have achieved patient-centered medical home designation and want to maintain it, that they are rated based upon a combination of the PCMH capabilities that they have in place in conjunction with their quality scores. And what we've seen here at UP over the past several years is that as more and more offices are implementing more capabilities, that the differentiation based on the number of capabilities has really become, there's much less variability between practices. So, it used to be we'd have some practices with maybe 40 or 50 capabilities and others in the hundreds. Really, most of our designated practices are in the 60, 70, 80, and above. So that the determination of whether a practice is designated or not is being determined much more or influenced much more by those EBCR scores. So I just wanted to point that out. So we'd like to open things up for questions. We might not have all the answers, but we certainly can get any information or that you need. So any questions on the reports?
Is there a minimum cases that are involved in that report?
One other comment. We've been traditionally reporting generic use rate, but one trend that we're seeing with the plans, Blue Cross included, is a move toward looking at the per member per month pharmacy cost and benchmarking on that basis. We've had physicians say, well, if my generic use rate is higher, then my cost should be lower. They don't always track, correlate one-to-one on that. So in the future, we are going to be including in our reporting the PMPM pharmacy cost as well.
Are they? This is Beth. Are they ever going to track physicians that use, when they're the lower cost like metformin's free at Myers? That doesn't count. It's not included in these scores, correct? Are they ever going to be able to track that, or?
I'll take that one. This is Jeff. A couple of things on that. Great question. First, the health plans are working a lot with the pharmacies that they contract with to make sure that they are asking people who get the $4 scripts, the free scripts, so they can submit that to the health plan for data. However, probably a better answer is that the focus on generics, while there's still going to be a focus, it's going to shift towards pharmacy cost.
Okay.
Meaning that if you have a lot of patients that are on a generic script they can get for $4 at Meijer, obviously that would bode well as far as cost because it's not really a cost that the healthcare system is burdened with. So I would say that that's a good practice and something that you wouldn't have to worry too much, I think, moving forward. And just to keep in mind that all of the physician organizations, obviously across the state, who are being evaluated for generics are kind of facing the same problems.
Thank you.
Thank you.
Is there any minimum volume for reporting?
Do we have any other questions? Okay. So I guess we'll move over to the specialist trend reports. So we took some time to describe the metrics in the PCP reports and point out some key things to focus on when you're reviewing. So I'll take just a couple minutes here to point out some of the keys for the specialist trend reports. The data in these reports are calculated a little bit different than the PCP. So the data here reflects only services that you as a specialist provided, which is obviously different from the PCP trend reports. Those included all services provided to that PCP's attributed patient population. The measures themselves are also a bit different from the PCP report. We have somewhat limited data when it comes to specialists from the health plans. However, that's quickly changing. Moving forward, we're pulling together data and reports for our specialty steering committee members to disseminate to their colleagues. In addition, we have a new reporting tool developed by the advisory board called Crimson that we'll be using hopefully next year to do most of our future reporting. And this tool has some other capabilities that we didn't have before. We can provide both PCPs and specialists some more drill downs and indications of performance across specific diagnostic and place of service categories. But as far as we're concerned today, the trend reports obviously is our first point at looking at data. So the specialists have two trend reports. In this case we have up on the screen, this is an example of a cardiologist. And this is the Blue Cross Blue Shield of Michigan Specialist Physician Trend Report. So with the Blue Cross report, the generic use rate and average pharmacy costs are probably the most actionable measures on this report. One thing to note, the benchmarks for these reports represent the average score for your specialty. So as a cardiologist, the generic use rate here of 82% you see on the screen is just based on all the cardiologists that belong to UP. Pharmacy seems to be an area where there's some low-hanging fruit for specialists to lower cost of care. And I'm going to actually see if you could go over to the managed care specialist trend report. It's a little bit different than you see on the PPO, the Blue Cross Blue Shield of Michigan Specialist Trend Report. There's generic use rate, we have average pharmacy cost, and then fourth down is average medical costs. So the average pharmacy and medical costs are I would say, important measures to focus on. And then like we saw before, there's the performance index. So as a specialist, with the common medical conditions that you would treat a cardiologist or a gastroenterologist, it compares your cases and the cost, the total cost, against all of the other specialists in your specialty. So it's a peer-to-peer group comparison. And the same thing, a higher performance index indicates higher cost. And before I'd mentioned that it takes into account this case mix. So there's actually a score here for case mix. In this case, the cardiologist has a much higher case mix compared to the rest of his or her practice. And just in general, that case mix over 100% does mean that you have either an older or a sicker patient population. It's based on age, gender, and diagnosis.
So Jeff, we have one question related to this. Dr. Madden, is there any minimum volume of cases before a category is reported? And I know on the performance index, that's one of them that there is a specific number.
Great question. I believe that number is 30. I don't know if we have Diane or Lee from our informatics team at UP on the line to confirm that, but in order to populate a performance score for you, 30 cases is a minimum threshold.
Yes, Jeff, this is Diane, and you are correct.
Thanks, Diane.
Thanks, Diane.
You're welcome.
With some of the other measures, I know that was a general question. When we get data from the health plans, so if you're a PCP and you have a radiology score, they apply the same methods when they calculate your population-based score. 30 is a pretty standard number in the health informatics world to get a confidence interval for your data as a physician. So I would use that kind of as a, I don't know what the word I'm looking for.
It's probably about how many cases.
I don't want to say measure, but.
You know, and again, maybe not
number of cases.
with the Beaumont physicians, but, you know, some of the physicians in practice may participate, you know, in Blue Care Network, but not in HAP. So they would not have that HAP data reported.
And in that case, you would see the NA not available next to your score. Did that answer your question?
Yes.
Okay. So with regards to the specialists, our focus moving forward is to establish a working groups and formal steering committees, which basically will be charged with identifying areas within your specialty that we can improve patient outcomes, limit duplication of testing, finding lower cost or generic equivalents for prescription drugs, and avoiding unnecessary procedures or imaging studies that occur outside the boundaries of new evidence-based guidelines. Ultimately, these are all, this effort with the specialists is focused on driving more cost-efficient care. And the trend report is a starting point just to gain some insight as to where you may stand as an individual physician. The general message here I think you should leave with is, while individual data is great for you to obviously know where you stand and how to make performance improvement in your practice, the better off we do as a whole, as a physician group, the better off everyone does. That's the idea of population management. So we're looking at these things not only at each individual physician level, but also across our network.
So one of the things that I think Jeff alluded to in the beginning, if you're looking at your trend report and you see an area where you feel your performance could is headed in the not the desired direction, or it's not where you want it to be, we can, and I think probably Wendy would be a good contact point, we can drill down. So say, for instance, on the generic use rate, if your GDR is trending up or it's above the benchmark to start with, or trending down, I'm sorry, I'm going the wrong direction on that one. It would be great if it's trending up and above the benchmark. We don't have to do anything else. Now, if it was trending down, we can get you a list of the medications that are prescribed. If we can also do an analysis to look at, in terms of some of the radiology studies, how many were ordered by you, how many were ordered by the specialists that you refer to, because as Jeff mentioned, on the PCP Blue Cross data, it's all of the care that's delivered to your attributed population, whether you directly put the pen to paper and ordered it or a specialist did that. So, you know, if you're finding that there are areas you want to do a little bit more analysis, we'd be happy to help you out with that. We have another question from Dr. Madden. So how are total RX counts comparable for docs with different panel sizes?
The total RX count, the total prescription count here is just a FYI, I would say. It's hard to compare just a straight number like that if you've got obviously more physicians in your panel. It's just to give you a general ballpark of where you are as far as how many prescriptions you write. I'll go out and say here that it's not necessarily a measure of performance. Specifically, the health plans that are measuring performance for any of the incentive payments or how UP does any evaluation on practices. So it's just a piece of information to supplement the rest of your report.
One of the challenges on the specialist reports is that, for instance, on the primary care physician reports, we can report out per member per month cost, but because patients aren't attributed directly to a specialist, it's very difficult to have that same measure. And our plan moving forward would be to, likely pull some of the items such as this and replace it with more specialty specific information. And this is an iterative process for us in terms of, how these, I think what you're looking at today is going to look different 6 months from now and 12 months from now in terms of what we're reporting back. So Dr. Madden's followed up, why not report prescriptions per patient?
It's a very great suggestion.
Great idea, yeah.
One of the other things, too, I wanted to point out, I'm not sure if I mentioned this, when you're looking at your trend, the graphs on the left side of the report, each data point for each quarter actually represents a 12-month period. So it's not an additive number throughout the year or on this report. Every number there in the trend box, it represents a year's worth of data. It just rolls over to the next quarter. So we do have a couple webinars coming up that I wanted to bring to your attention. We're going to be looking at similar categories, radiology, emergency department, and generic utilization. But we're going to do a deeper dive and identify patterns across our network and real opportunities for improvement. So we have a radiology webinar scheduled on Wednesday, November 6th from 12:15 to 1 p.m. We have an emergency department utilization webinar scheduled November 13th from 12:15 to 1 p.m. And then we have a generic utilization webinar scheduled December 4th from 12:15 to 1 p.m. If you receive a notification from UP or Beaumont administration that directly invites you, we strongly encourage you to participate. Or if you see trends in your data and you see that you're below the benchmark, we also invite you to participate because, like I had mentioned before, the better we do as a group as far as these metrics go, the better off everyone is. I also want to remind you that we have a leadership meeting. It's the UP quarterly leadership meeting coming up on Wednesday, October 23rd at the Centerpoint Marriott from 6 to 8:30 p.m. Registration starts at 6. We have a great speaker, Dr. Genord, who was a member here at UP and is now the Chief Medical Officer at Health Plus, talking about population health management, which is a perfect segue into these reports. So 6 to 8:30 p.m. Centerpoint Marriott, Wednesday, October 23rd.
And just to expand on that a little bit, this is Kim. So Dr. Genord is going. As I think many of you know, he's been very involved within the Beaumont Health System, and then as an associate medical director at United Physicians, he's currently medical director, chief medical officer at Health Plus. So he has a unique perspective that we asked him to share with us. But in addition to that, Dr. Williams is going to be providing an update on specific approaches that United Physicians will be taking over the next 12 months to help us collectively be successful in population health, in a healthcare system that is looking for population health outcomes. We'll also be providing important updates on the Medicaid expansion and the health care marketplace and what that may mean to you on a very practical level. So we'd encourage everybody to attend if you're available. We'd like to have that opportunity to provide those updates and answer any other questions. So Jeff and Tanya and I will stay on the line for a few minutes. If there are other questions, by all means, please feel free to ask. We're open to, if there are even topics maybe tangential to this, we'd be happy to answer any questions that you have.